So welcome everybody to the last session of the day. We've got the marathon runners in the audience, the people who've got the stamina to see right through the day. Thank you for being here. I'm sure we're going to have a fabulous session on theranostics this afternoon, a new and emerging and very exciting area, even though theranostics has been with us really since the birth of nuclear medicine. It's really making giant leaps, and particularly apt, I think, that we have our first speaker, Professor Steve Larson from the Memorial Sloan Kettering Institute in New York, has really been one of the pioneers in molecular imaging and therapeutics. And we really look forward, Steve, to your talk on molecular imaging and oncology drug development.
Thanks very much. It's a great pleasure for me to be here today and to see the vitality of the nuclear medicine in this part of the world is fantastic. So, Rod, what do I push here? Oh, here we go. Big
green one.
Today I'll talk about theranostics, and by that I mean a drug or biological with both diagnostic and therapeutic properties. I-124 and I-131 I call a theranostic pair because they, same element, same properties, but both diagnostic and therapeutic purposes in terms of that pair. So this is my outline of the talk. I'm going to talk about thyroid cancer and the exciting area of radioiodine resistance and reinduction of iodine 131 uptake, castrate-resistant prostate cancer. I'm going to show use of androgen receptor imaging in that setting, again, in the context of drug development. CNS recurrence of neuroblastoma, and looking at some exciting data that we recently have harvested from studies that have gone on actually for almost 2 decades to show long-term remission with targeted radiotherapy. And then talk a little bit about the role that theranostic plays in preclinical drug development. Especially interesting is multi-step targeting for the high therapeutic index. I won't have time to talk about some topics today, but I'll allude to them, and perhaps you can, those of you who are interested can pursue it on your own through these references. So, molecular imaging for the study of radioactive iodine resistance, it's a big problem in thyroid cancer, and surprisingly, it's not something we've talked about too much because we can't really do very much about it. I wanted to mention Saul Hertz because he was a fighter. He was a person who went through a lot of prejudice and resistance, lack of funding to do the initial radioiodine therapy studies and to create paradigms for theranostics. I think we owe him a tremendous debt. His daughter, Barbara Hertz, is here. I urge you to go by her booth, which talks about his story. Now, the clinical problem of radioactive iodine refractory thyroid cancer is serious. So we know that distant mets are the most frequent cause of death for differentiated thyroid cancer, and that the radioactive iodine incorporation reduction or absence is associated with high mortality, and we need new therapies for this condition. So these are some clinical states in which we use radioactive iodine. In the first instance, we use it to treat after the primary tumor has been removed as thyroidectomy, as ablation therapy. We use it to evaluate recurrent and metastatic disease, and we see that there are 2 types, one of which takes up radioactivity, as you can see here, outlining the lung and the patient in the center panel, and then also outlining in another patient with equal amount of disease, but with absent uptake. Is this do we have a,
Yeah.
is there a laser pointer on this? Am I just not seeing it? So that's the one. Just push that one. Got it. All right. Okay, good. Got it. One of the great things about recent studies of solid tumors has been the Cancer Center Genome Atlas, which is a collection of tumors, and these have been extensively studied. And with respect to thyroid cancer, you may not be aware that virtually 95% in prostate cancer, the well-differentiated form, driver oncogenes are known for these tumors. And the large majority involves the MAP kinase pathway, which is shown here schematically. Now, we did a study, which 20 patients I'm going to talk about. This was a breakdown of where their oncogenic change was. 15% had a change at the receptor, 25% had a change in the RAS, which is sort of the starting transmitter protein, and 45% had a change in BRAF, especially the common V600E mutation. This is the same mutation that melanoma is prone to. Now, the reason that that's important is because it was appreciated by my colleague Jim Fagan and his lab mates that you could actually reinduce uptake of radioactive iodine with proper treatment of tyrosine kinase inhibitor to inhibit components of that pathway. For example, here he used this model, which was a doxycycline-inducible oncogenic BRAF. So in the germline, they had a thyroid. In the thyroid, they could turn on and off a tumor. And as you see here, the thyroid was normally functioning, but when they turned on the BRAF V600E mutation, the iodine uptake went down. This was I-124 uptake done partly with the help of Elmer Santos, who's now at MD Anderson. To make the long story short, you see that when they used either inhibitors of BRAF V600E or the downstream protein, which is MEK, they were able to induce the uptake. Here, look at this panel. This is with the doxycycline-inducible V600E fully blown. This is simply with additional treatment of either the blocker of the BRAF or of the MEK. And you see it was reinduced. Now, that was used as a basis for a clinical trial, which was organized like this. So you had Silumetinib, which is a MEK inhibitor. You see it here. It inhibits this protein in the chain. And what happens with the inhibition is there's a drop in proliferation, and then differentiation genes are activated when there is a slowing of the division. And the important one here is the sodium iodide symporter and NIS. We used I-124. This was baseline images, and then we studied the patient under treatment. Of course, you know that I-124 allows quantitative imaging, high-resolution imaging. Here's the organization of this particular protocol. Silumetinib was given after the baseline studies for a period of 2 to 4 weeks. In the last week, an I-124 PET scan was done. The assessment was whether you got uptake or not. If you didn't, Silumetinib was discontinued. If you got enough uptake, a positive response, then it was continued and the patient went on to I-131 therapy. I'm not going to talk too much in detail about the genetic component of that, but I'll allude to it at the end. So here's a patient baseline. You just see the uptake of the I-124 in the esophagus and the gut. No uptake in known disease in the lungs until you get the post-Silumetinib stance. So in 4 to 5 weeks, there's induction of all this uptake in right supraclavicular region and also in the lungs. If you look at it on a plot which looks at the pre-treatment SUVs on this graph, which were all 0, you see that there was remarkable induction, particularly of some lesions. Turns out that we have developed a way to look at a threshold for uptake, which I'll mention in a minute. But it was not only in the lung that we saw this kind of uptake, but look at this lesion here in the bones of the pelvis. Very faint uptake before in the baseline, and then tremendous uptake after treatment. So what we found was, again, this kind of uptake induction. Here's a patient. You see the lesion here. This is very common. The lesion loses the ability to take up radioactive iodine, but when treated with this sulimetinib, there's uptake. What we found was that 12 out of 20 patients had the increased uptake, and 8 out of 12 had enough to be treated. When we say enough, we selected a threshold of greater than 2,000 rads for any lesion. This was the reference, which I urge you to read, Ho et al., New England Journal in 2013. This is what we did. We used a single measurement of uptake. We, from prior work, knew that approximately 48-hour clearance of the radioactive iodine in this condition, and computed this. And it turns out if the SUV is 20, you'll get about 2,000 rads calculated from this formula. So there were 7 patients who met the criterion, and then RECIST was used to assess at 3 months after treatment. You see that there was excellent response in really in all of them, but significant PRs in 6 out of the 7 patients. So in summary, you can do this now with sulimetinib to enhance iodine incorporation, and this is being studied now not only with sulimetinib, but other combination therapies to make it even more effective and homogeneous by Ho and the colleagues there. There's a tremendous amount of interest in this, and this is a common plot that's used to show genes in comparison. Each column is one patient. These are differentiation genes that are known to be important in thyroid cancer. This is particularly important in this. Now, at baseline, without treatment with these TKI inhibitors, this is what you see. Most of BRAF V600E, for example, is not able to take up much iodine because the genes are not active. But what we have done is to develop a differentiation gene score and correlate that with the actual uptake. So here we have 3 patients studied that way. In green is the score, which essentially summarizes the genes that are active in iodine uptake. And you see this correlates with the uptake. Here we see a patient before and after, for example, with this neck lesion. The induction is greater than, the SCV is greater than 21. One of the other interesting features is that there's an inverse relationship between the iodine uptake and the FDG uptake, and this is also under study. FDG uptake is a marker of dedifferentiation. I-124 uptake is a marker of differentiation. Now, I also want to talk about the development of another set of agents and the role that molecular imaging has in that circumstance. We looked at inhibitors of androgen receptor access using FDHT particularly, as well as these other agents. These are my colleagues who have worked with us, Mike Morris and Howard Chair particularly, and then Neil Bander did a lot of work with us on antibodies. I won't talk about that today. The key point here is that what we find is in prostate cancer, clinical states are very important to the outcome and also to the drugs that can be used to help the patient. For example, clinically localized disease, many patients have satisfactory surgery, maybe 2/3, but then the third, even though the prostate's been removed, will develop rising PSA. And then clinical metastasis in the non-castrate setting, and then castrate as the castrate setting with rising PSA, and then metastasis develop. Each of these requires specific treatments, and drugs. Now, we've studied the androgen receptor axis in this setting, and here we've used FDHT, which is an analog of dihydrotestosterone labeled with fluorine, developed originally by Katzenellenbogen and Welsh in the late 80s. And we characterized it, did a lot of pharmacology to understand this tracer and its usefulness in metastatic castrate patients. So in addition to that, what happens is the FDHT, just like DHT binds to androgen receptors and carried into the nucleus where it binds to DNA, and then this tracer also is involved, just like DHT, in inducing effector molecules downstream, which include PSA, PSMA, HK2, and STEAP as some examples that can be imaged. So, to make a long story short, we've done a tremendous amount of work. Not only us, but the group at WashU, Didashti et al. Showed that you could displace this with flutamine. She was the first to do that. We showed that it was feasible to do imaging in metastatic disease. This was the first patient we studied with the drug. You see that there's uptake in the metastatic sites in bone. Here's one in skull. You see there's very little uptake in brain. It's excreted through the liver, the drug itself, and the half-life is very short, actually only 8 minutes for the active compound, and yet SUVs are about on average 7 or 8 for this tracer. Now, one thing you can do is use the FDHT to show how drugs that block androgen receptor axis are working, whether they hit the target. So in our first instance, we did studies in vitro, and this is, if you have, here you have a model where you have an androgen receptor which is labeled with GFP, and with tiny amounts of the tracer, you don't see any incorporation. You only see the androgen receptor out in the cytoplasm where it normally lives. But as you go up to higher amounts of FDHT, what you do is you see it pulling into the nucleus. So this radiotracer is an agonist with an IC50 of about 2.7 nanomoles. So it's quite a good tracer for the actual, to show drug effect. So the initial study was done here with the enzalutamide drug. These are the initial studies. Patients were imaged in the castrate state. You see uptake all along the spine in this patient. With treatment with enzalutamide, all of those sites go away, and you see here a group of patients for whom that was determined. So the sites are hit very well with this. Similarly with apalutamide, which is another drug developed also by Charles Sawyers and his team, it has some better characteristics in terms of not being as susceptible to mutations in the androgen receptor. But we use the FDHT tracer to do displacement studies. So this is increasing doses of the drug on this axis, and you can see that the SUVs gradually decline until you get to a biologically effective dose, which incidentally is well below the doses that induce toxicity. So the company used this to choose the appropriate dose for their phase 2 trials. That's also now been an approved drug. A number of these drugs that we see now have been approved for metastatic prostate cancer and have prolonged life in these patients, including now radium-223, obviously, but for abiraterone and for enzalutamide and for the apalutamide, we use those FDHT tracers, and also, don't have time to go into it, but we developed a way to use bone scans to overcome the flare phenomenon, which has been accepted by the FDA now as a biomarker, and it was quite helpful in getting these 3 drugs approved for use. Another example of theranostics, again, in theranostics value in drug development is shown here. This is my colleague, Naikang Chung, who years ago, about 35 years ago, discovered antibodies that were useful in targeting to GD2 antigen in neuroblastoma. What I want to talk to today about these excellent antibodies, and another one here, 8H9, also developed by Chung, and the role that I-124-3F8, for example, has played in tumor dosimetry, and the long-term collaboration that we've had has resulted now in successful treatments in otherwise children who would have gone on and died. So this is the way we use it. In this case, this was an antibody injected into the ventricle, and then what happens is it goes down the spine. We used I-124. This is at 48 hours, but we had sequential studies to show first clearance from the CSF. In a compartment like this, what happens is the unreacted antibody is pumped out through the Pacchionian granulations. And in this case, the 8H9 is captured in the liver to a less efficient extent, but you can see that it's in the systemic circulation here. But it's injected into the ventricle, and when cleared, you can see that the tumor-bound activity stands out. We can use that to calculate dose both to the tumor. In this case, 60 millicuries was used in this phase 1 patient. It gives about 4,000 rads computed to that with a therapeutic index tumor to blood of about 31, because that can be determined from the I-124 as a theranostic. But the important point is that now this data is now mature and has served as a basis for a trial, a phase 2 trial, and you see here that before the addition of this I-131, then treatment as a theranostic, this is a phase 2 separate series of patients from this. The dose that was finally chosen was 50 millicuries times 2, and you see that 56% of these patients have long-term survival. Otherwise, they would have died. And look at the size of this mass here in the brain. This is neuroblastoma. 5-year survival on MRI, actually 15 years already, this particular patient free of disease. It's remarkable because I can remember when these patients came in and they really just died. You know, it shows you that you must persevere. Both Chung and I were criticized for treating these patients because there was a lot of work for everybody, and the patients themselves were put through this kind of thing, but it was worth it in the end because they did go ahead and get long-term survival. And that's what we must do with our therapy. We have to shoot for cures. What we see as palliation is good, but it's just a start. Now, one thing we've begun to do is to seek cures. And one of the things that we've been working on, Chung and I, with Sarah Cheel, who is an outstanding postdoc and now a senior scientist in my lab, is to develop a platform that can treat solid tumors. So we have now 9 of these for different kinds of solid tumors, and this is an example in colorectal cancer. So what is done is you have a triple sequence. You inject the platform without radioactivity. You then clear away any unreacted antibody that's not bound in tumor, and then you give the hapten radiolabel, which is a lutetium-177 peptide. It binds to this very, very high affinity binding site. Now, and this is the results. You see this, the controls are in blue and they die, but the treated, after 3 cycles of this treatment, 10 out of 10 of the animals with colorectal solid tumor xenograft at approximately 200 to 400 milligrams got complete responses that were followed out 140 days. We saw that they were pathologic responses. So it's something that we can do for solid and liquid tumors. We've now set up a small company to try to promote this activity and to raise the money necessary, because each of these will probably cost about $4 or $5 million to get it into the clinic, and it's just impossible with NIH money. So these are the personnel there that are working on this problem. just again, this is both a diagnostic and theranostic. So what we've shown here is excellent targeting, and you can follow this. This was done at the arrows, each of these 3 images with lutetium. You see the therapeutic indexes for blood and for kidney, 93 for the blood and 16 for the kidney. So this is feasible now with these reagents. We can do this. We must push for this sort of thing. Same can be done with Herceptin. You see cures here in these tumors, 5 of 5 CRs and cures. We also see with GD2 targeting, we see the same kind of thing, very, very high area under the curve and for therapeutic index with this system as well. So it's a modular system, which we call DOTA-PRIT. The therapeutic indexes can be achieved are very, very high. Now, I want to emphasize that we've used theranostics to kind of pull us through this process. This has taken about 7 years to get to this point, and the imaging has been very important, but we validated it with comparing it to counting in a test tube, laborious studies. So the theranostic with lutetium now with SPECT is within 8% of the value that we obtained with the sacrificing of the animals and counting in a test tube. Now, this particular approach depends on this very, very high affinity anti-hapten antibody, which was invented by and developed by Dane Wittrup and his colleague Kelly Orcutt at MIT. And it only binds lutetium and yttrium with low picomolar affinity. It doesn't bind other lanthanides at all well, and it ignores free DOTA, 3-armed DOTA, et cetera. So this is kind of a blessing in one way, but it also can be a curse because we want to target, for example, other alpha emitters, actinium. So we've been inspired by the work of Scheinberg, who is very interested in alphas and has created clinical scenarios in which alphas are used in patients because of their shorter half-life. So we developed a method to adapt to the DOTA approach, same approach that we use, but something we call Proteus DOTA, and here's how it works. We have essentially another chelate which doesn't interact with the hapten antibody, but which binds actinium. And we use as an affinity handle the lutetium, DOTA-PRIT. So you see that what happens is we show that it's absolutely identical to the actinium clearance. So we measure actinium and we measure our DOTA-PRIT. So we get very, very good localization to tumor. Now we needed something that we could image, so we put indium into that same spot where the actinium is, and this is the image with indium. So we've shown excellent comparison between the actinium. We're using this now as a surrogate so that we can do external imaging. And Ed Fung is the medical physics postdoc who has done this work with us. Now, I think that we must continue to work on these targeting agents, novel agents that are going to harness the power of atomic energy to cure cancers. We're beginning to see in radiopeptide therapy, for example, remarkable responses. And that's a great step forward, but we must shoot for cures. So with the actinium-225, for example, with the HBED compounds, with a variety of PSMA targeting agents, we're seeing wonderful responses. We must shoot for cures. And we can't be discouraged by people who say, well, look, you're going to damage normal tissues, because these patients need something to, of course, protect their normal tissues, but even more important, they need to live. We need to think in terms of these kinds of technologies that as curative, as an alternative perhaps to other curative treatments, but certainly curative. And in solid tumors, as we know, there's very little that we can say does that. We need doses of 10,000 rads to the tumor or more. We need to know that renal doses, we should probably keep less than 1,500 rats in order to avoid any toxicity. Bone marrow less than 150, colon mucosa probably less than 250. So that sets limits on therapeutic index that we can use. So today I've tried to show some ways in which theranostic imaging can help us in drug development, both in thyroid cancer, castrate-resistant prostate cancer, and also in neuroblastoma and other kinds of CNS recurrence, and for preclinical development to help us develop these outstanding agents. I think that many people have helped in this project. This is my lab group here, Sarah Cheel particularly in the middle there for the projects that I've mentioned. This is our team which brings it all home and does this particularly Nita Pandit Taskar, who is standing on the end here. Unfortunately, Wolfgang is no longer with us. I don't mean he's died, but he's gone to Munich, which is unfortunate for us. Heiko is the interim. So thanks very much for your attention.
Yeah. Thank you very much for that very erudite presentation, and congratulations for the fantastic work that you've done over a very long career, and for the team that you've built who continue that work. I think for the sake of time that we will move on, but really a fantastic talk, Steve. Thank you very much.
Thanks very much, Rod.
So our next speaker is Dr. Andre Garu. Andre is the head of nuclear medicine at Stanford University, and he'll be talking to us today about bench-to-bedside efforts with peptide receptor antagonists targeting RM2. So please welcome Dr. Andre Garu.
Thank you, Sam. Good afternoon, ladies and gentlemen. Thank you for staying till the end. I hope it's not the bitter end. As you can see from the title, one disclaimer is that I'm not going to talk too much about PSMA, and I know that you've heard a lot about it. I hope I will get you at least a little bit excited about the gas-releasing peptide receptors as a tool for both diagnostics and therapy. The second disclaimer is that, although I'm going to talk of bench-to-bedside, the bench-to-bedside did not happen entirely at Stanford. We are intimately involved with the clinical translation, but we did not conduct the entire data collection that I'm going to show. This is an outline of my talk. I'm going to give a brief introduction. I will recognize what others are doing. And then the bulk of the talk is going to be the bench-to-bedside theranostics use of RM2, which is the bombesin antagonist that we are using. I will end with future directions. This is data that was just published showing the estimated new cancers in the United States in 2018, and you can see that in men, it remains the highest incidence of cancer, and it is a second cause of death from cancer in men in the United States. So, as the previous speaker said, we have a lot of work to do, not just to arrest disease, but also to try to cure these patients. What is the gas-releasing peptide receptor? This is a G-protein coupled receptor that is overexpressed in a variety of cancers, including prostate, but also in breast, small cell lung cancer, as well as tumor vessels of urinary tract vessel. It's an attractive target, and as I said, I hope to convince you that that is the case. I'm not going to spend too much time describing agonists versus antagonists. For JRPRs, it's important to recognize that although most of the work started targeting these receptors using agonists, it was soon realized that the side effects that were noted when injecting them into patients were making this use a little bit difficult. So most of the work that's being done now, it's using antagonists. Most of the clinical work is done using antagonists. As far as I know, there are only 2 agonists that have been translated clinically, and these are mentioned on this slide. I'm not going to say much more about them because I do not think that they will be further developed because of the side effects that I mentioned earlier. But these are the antagonists that are currently in clinical trials or have been put in humans, and RM2 is noted here. This one, it's a first generation that was optimized into the gallium-68 neobomb. This is a fluorinated version, and this is a copper-64 labeled version of a bombacine antagonist. How does it look once you inject such an antagonist into patients? This is a normal biodistribution in an RM2 scan. So you will note that the pancreas has the highest uptake. Clearance, it's mostly through the kidneys. You see ureters and bladder. There's minimal hepatobiliary clearance, which means that in the abdomen and pelvis, you will have a clean image without a lot of bowel uptake. Also, if you think that this may work in breast cancer, it's worth noting that there's not much above the diaphragm as far as uptake goes. Just briefly, what has been done so far with this radiopharmaceutical? There is a pilot study with preclinical and first clinical experiences. This version of an antagonist elicited no adverse events. However, there are some reports of not being too stable, so it was further developed into Neobomb 1, which is now licensed by Advanced Accelerator Applications from the group in Athens and Erasmus, and I believe there are plans to take it to clinical translation and hopefully for approval, both for diagnostic as well as for therapy purposes. This is one of the papers that was published using this agent, Neobomb 1, and this has potential application if labeled with gallium-68 for diagnostic purposes, and if labeled with lutetium-177 for therapy purposes. Of course, gallium-68, especially in a large population like prostate cancer, comes with logistical nightmares, I would say, if you want to distribute it commercially. So people try to label this with F18, and this is the same compound as RM2. Turns out that if you label the RM2 with fluorine-18, you change the conformation of the molecule to an extent where you are unable to identify all the prostate cancer. So in this comparison by the group in Zurich, actually this did not perform as it was expected, and I think there are no further plans to develop this particular molecule. I still think that in the long run it would be great to have a fluorinated version of a bombacine antagonist if this is to be successful commercially. We were in a session earlier where people discussed dosimetry, and of course it's difficult, if not impossible, to do dosimetry with gallium-68, so having a longer-lived isotope such as copper-64 would be appropriate. It will allow you to do imaging up to 12 hours, which is still not as far out as some experts would suggest, but it will be definitely better than copper-64. And this is the group led by Wolfgang, who we've heard about earlier, that's shown that you can actually use this agent to identify prostate cancer based on the GRPRs. So now let's focus on the theranostic use of RM2. And here I will present the preclinical experience, both with gallium-68 labeled RM2 as well as with lutetium-177 labeled RM2. This is the structure of the molecule, and you can see the gallium-68 attached here. Of course, like everything that has to be put in humans, you have to go to a variety of tests in animal models, and this is safety data. And there was no observed effect level. There were no noteworthy findings, whether you look at central nervous system, cardiovascular system, or respiratory system. If you want to see binding affinity, that is mentioned in the table at the bottom of this slide. If you want to see, this is a model of cells, PC3. It's a model that overexpresses GRPRs, and these were treated either with bombacine alone or bombacine with RM2. And RM2 behaved, as shown in this graph, as an antagonist because it shifted the dose-response curve of bombacine to a higher molar range. This table compares the distribution of gallium-68 RM2 in models that overexpress GRPRs, such as PC3, and those with low overexpression of GRPRs, the other model. And they were compared with fluoroethylcholine as well as with FDG, and the uptakes are comparable. The biodistribution is favorable for clinical translation. And if you look at the tumor to different tissue backgrounds, you see in green the gallium-68 RM2 has high tumor to different organs ratios, which indicate that the uptake and concentration in tumor lesions is highly favorable for clinical translation. This is an example illustrating the tumor here implanted in a mouse model, and then it's blocked. So this illustrates very good tumor targeting and low background uptake with this preclinical model of a tracer targeting the gas-releasing peptide receptors. This is preliminary work that was done at Stanford by Jürgen Willmann and Dan Spielman, looking at a mouse model and studying it with PET, MRI, and MR spectroscopy, trying to see if we really need to use everything to identify prostate cancer. And this was promising work that unfortunately was abruptly cut. And they were able not only to identify the tumor, but also to use this system to guide where to biopsy and what benefits would come from having together MRS, MRI, and PET. This is preliminary preclinical data looking at the lutetium-177 labeled, in this case, RM2. And here is shown that in animal models, this appears to be effective as a single agent in vivo data. And as someone said in a session, I believe earlier today, we should shift for this from as low as reasonably achievable in diagnostic tests to as high as safely possible. And you can see here that the more you give, obviously, the better the responses will be. So we have to keep in mind safety, but we should shoot for as high as possibly given to this patient if we are to have a chance to treat them, not just to cure them, rather, not just to arrest disease at a certain stage. If you combine lutetium-177 RM2 with rapamycin, you observe better response rates, which is illustrated on the graph on the right here. So the work is not done. We have a lot to learn, including how to select patients for PSMA or RM2, for example, what doses to give, and what combination of drugs to give to achieve the most appropriate therapeutic combination in these patients. Importantly, also, in these preclinical studies, there was no treatment-related toxicity, and the images at the bottom demonstrate that there was no significant toxicity in kidneys or pancreas, which were the dose-limiting organs, whether you look at untreated tissue or animal treated with combination therapy of RM2 and rapamycin. So now let's switch to the clinical experience, and I will recognize first work done by others, and then I will share with you the work that we are doing at Stanford. The first study was done in Turku, and it looked at pharmacodynamics, whole body distribution, metabolism in men, and this is one of the first images that was published, dynamic whole body imaging, and it demonstrated that the biodistribution, once you inject this into humans, is as expected from preclinical models. One of the follow-up studies, also from Finland, from Turku, looked at patients at initial diagnosis and at biochemical recurrence, and the data was encouraging as well. And it stimulated others, including ourselves, to proceed with clinical translation of this radiopharmaceutical. Interestingly, and a good sign at that time was the fact that BPH, benign prostate hypertrophy, those lesions that were attributed to BPH did not have high uptake of RM2. And here the graph on the right illustrates the uptake in prostate cancer measured by SUV versus BPH, with some overlap, but not significant overlap versus normal prostate tissue. This is our recent publication of the initial data looking at patients who had biochemical recurrence, and we used two sets of criteria. Post-radical prostatectomy, we used the AUA criteria, so we required two measurements, two PSA measurements of 0.2 or more at least 6 weeks after surgery. For those patients with prostate intact but treated with radiation or hormonal or chemotherapy, we required a PSA rising at least 2 after nadir was noted. They also had to have negative CT, MR, and bone scans as an inclusion criteria, so a pretty tight set of criteria. And these are the results summarized. So far, we have 67 prostate cancer patients that are enrolled with a PSA mean of 8.7, and the RM2 PET MRI followed at about 29 days after the anatomical imaging was completed. What's important here is that despite this patient had negative anatomical imaging or bones cancer inclusion, we were able to identify recurrent prostate cancer in about 70% of the patient, which I think it's quite remarkable. MRI was only able to find recurrent disease in about 1/3 of these patients. And again, these were patients where prior imaging was negative for the detection of imaging. So images are 1,000 words, so let me guide you through a few cases. This is a patient who initially had a Gleason 3+4 score, PSA of 6.8, was followed for many years for biochemical recurrence without possibility to identify where the recurrence was. And I think that it's not difficult to identify that there is focal uptake in the prostate. This was biopsy proven to represent recurrent disease. And not only that, but this patient underwent radiation therapy, and at 6 months after that, there's no more uptake in the prostate gland. So perhaps there's another application here. Instead of biopsying these prostates or other tissues that are treated, which is typically done at 6 months, perhaps we have something that will allow us to identify responders and classify responders and non-responders. This is another example, and you will see the same team, patients that are followed up for many, many months. On average, in our patient population, 44 months. So 44 months of these men with rising PSA after treatment that underwent MRI, CTs, bone scans, biopsies, a lot of healthcare costs, a lot of anxiety, unable to find the source of disease, and we were able to help them with this agent. And so in this particular case, the recurrent disease was in small lymph nodes in the pelvis. These are 2 to 3 millimeter lymph nodes. So I think what we're effectively doing now as a community, we're punting the question back to the treating physicians, because it used to be that we can't find where the PSA is coming from. Now we know where it's coming from, but how do you treat? Do you have a brave enough surgeon who will go to dissect the fat there and try to find the lymph nodes? And if he does that, who knows what other sites of metastatic disease are present there that we're unable to see? Do you give radiation therapy? Do you give a combination? I think we have a lot of questions and not too many answers. So it's upon us to work with our clinicians, collaborators, to try to identify when is the appropriate use of these agents and what do you do at that point. Another patient, biochemical recurrence, in this case since 2009. So this was followed for 7 years without finding the source of disease. And some of these patients were treated blindly, and I think that most men with prostate cancer, when they hear the word castration, chemical or castration, they would like to know what are they being castrated for. And I think that our oncologists use these images as a tool to convince them that they need treatment. This patient happened to have a colon scan, and on the colon scan, there was uptake in this external iliac lymph node. And he also had the RM2. And here we see different set of lymph nodes on early and delayed imaging. Our protocol is to do an early whole body at 45 minutes and then do a dedicated pelvic PET MR afterwards. There were additional lymph nodes as well, and the lymph node that was positive on colon was not positive on bombesin. It was not biopsy, so I cannot tell you which one was the correct, but it illustrates the fact that biology is complex. It illustrates how little we know about biology in many diseases, including prostate cancer. It illustrates how much we need to learn about this. And this is yet another lymph node that was shown both on early and on delayed imaging. Another example, high Gleason score, received multiple treatments, PSA went up, no source of PSA. This was a lung nodule, and I agree that if this patient would have had a chest CT, we would have found it, but chest CT is not commonly used to restage patients with prostate cancer. We were also wondering if this was truly prostate cancer or it was a secondary or a second malignancy, lung cancer. This was biopsied, and it was metastatic adenocarcinoma of prostate origin, the only site of metastatic disease at biochemical recurrence. I like this case in particular. Let's see if anyone in the room would venture to guess where the recurrence is. Who thinks it's below the diaphragm? Above the diaphragm? Okay, I see a few people in both groups, so let's take a closer look. So this is on the liver capsule. Nothing to biopsy on CT or MR at this stage, so we label this as an abnormal finding of uncertain clinical significance and close monitoring. This is 4 months later, and now there is something to biopsy. And this was an MR-guided biopsy, and the result was adenocarcinoma of prostate origin, a liver capsule implant, the only site of biochemical recurrence in this patient. And I believe it's the last case I'm showing. It illustrates that these recurrences can be in location where we would say that they're unlikely for prostate cancer to go. On the left, we have a sodium fluoride and FDG, a cocktail concept that we still use at Stanford. And on the right, we have the bombacin, and there is abnormal uptake in inguinal lymph nodes. You can see them on the top with the combined approach, and on the bottom with bombacin, and these were biopsy proven to be metastatic prostate cancer. And this is another recurrence in the prostate bed, seen very well both on early and on delayed imaging. So of course, the question is, at what levels of PSA are you able to detect recurrence? And these are all our patients, all the 67 patients, and in red are the PSA values for patients with negative scans, and in green are the PSA values in patients with positive scans. I think that what's important in this slide is that our detection rates are about 42% for PSA values of 0.2 to 1, 50% of 1 to 2, 73% in 2 to 5, and 92% when patients present with a PSA more than 5. So one may fall into the trap of thinking that the PSA alone is what should guide what test to use. But I suggest that we take a look at this plot here, which illustrates the relationship between PSA velocity and the positive or negative scans. So majority of patients with a negative scan had a PSA velocity that was low, while all the patients with a positive scan had high PSA velocity. And we know that a PSA velocity that is high will predict an aggressive course of disease. So I would argue, and this remains to be seen in larger studies, that perhaps it's not a bad thing to have a negative scan, because maybe those are the more indolent prostate cancer that we shouldn't really rush to treat aggressively. As I said, we have a lot to learn, and this is one area where we need to learn more. Which are the patients that require aggressive treatment? Which are the patients where we can just monitor them and act when their disease becomes more aggressive? We are also looking at the use of gallium-68 in initial staging of prostate cancer. This is a project that just started. To date, we have 8 patients enrolled with newly diagnosed intermediate or high risk. And we do a very interesting work. Our urologists are using a 3D mold of the prostate gland based on MR. The prostate is taken out as one piece, placed in that mold section, then you can compare the histopathology slides with the MR images, and in this case with CT and PET, and you can see the correlation between the uptake on PET and in inked mark the prostate cancer. For all of these patients, we have extensive histopathology data, looking at how aggressive the tumor is, the volume in the prostate gland, as well as the presence or absence of nodal metastasis. This is another example, and you can identify clearly the prostate cancer. And it correlates very nicely on histopathology with the location of disease. And this is a summary crossing the midline, pretty large volume, 20%, and there were no lymph nodes, just like we have not seen lymph nodes involved by disease on imaging. And this is yet another example with multiple locations of prostate cancer within the gland. You see 2 areas of abnormal uptake. There were also lymph node disease here, and you can see the correlation with histopathology. We are currently working on developing an atlas of what's normal, what's abnormal in this patient population, and our goal is to be able to use AI to do a classifier of normal, abnormal scans. We can segment out the data based on PET and classify these scans and focus more on those with expected positive scans and less time perhaps on those with expected negative scans. The uptake in these lesions, whether they're located in the prostate bed or in nodal metastases, is pretty high as predicted from preclinical work. And before we end, it begs the question, how does it compare with PSMA? And we have some data. Some of these patients, if they're agreeable, are scanned with both bombacin as well as with PSMA. We, of course, are supporting the use of PSMA. It's probably God's gift to nuclear medicine. It helped the way to grow the field and will have a big role in the management of these patients. But I do think that given the length, the duration of prostate cancer, how long it takes to progress, it cannot be a single target to be good at all stages of disease. So we have 29 prostate cancer imaged to date. The RM2 was positive in 20 of them, PSMA11 in 21. There were more lesions. The RM2 was positive and the PSMA was negative in 2 patients and the vice versa in 3. And the extent of disease with RM2 was more than on PSMA in 3 and vice versa in 4. So there is overlap, but no perfect overlap. So there, in my opinion, there is a role for both agents in prostate cancer. This is one example, patient who presented with a long course of disease. And this is someone who could afford to go and be seen in multiple places. So this patient was seen at Stanford, had biopsies and scans at UCSF, flew to Mayo to have a colon scan, flew to UCLA to have an acetate scan, and we intercepted him to have a PSMA and a bombacin scan. And this is how his scan looked like. So on the left, we have the bombacin, on the right, we have the PSMA. And I would argue that these retroperitoneal lymph nodes are more conspicuous on the bombacin than they are on the PSMA. You would say, does it matter if you see 5 lymph nodes or 3 lymph nodes? Probably not. But if you are to radiate, for example, these nodes, I think that it's good to know the true extent of disease so that you don't miss some of those lymph nodes that are involved by disease. This is another patient. And you would see here on the left, again, the bombacin that demonstrates some retroperitoneal lymph nodes, and some of them are also seen on the PSMA. The finding that was most intriguing to us was this area in the pelvic cul-de-sac that was actually slowly growing over time on anatomical imaging, but of course we fall into the trap of looking only at the 1 or 2 most recent scans. If you look at this area over 5 or 6 scans, there was significant growth, but it was not caught. Both the RM2 and the PSMA identify this as a site, a location of recurrent prostate cancer. This is another patient, and you can see a nodal metastasis on both the RM2 as well as the PSMA. I use this slide to illustrate that there's no uptake in salivary glands with RM2, so we don't expect when we use this for therapy to have side effects such as dry mouth. And of course, we want to catch these patients before they get to this stage where they have extensive disease. You know this is an aggressive prostate cancer. This patient had a whole body MRI and a bone scan 2 months prior to the scan that were clean. So this patient developed such extensive disease in a very short course. And you'll probably appreciate that some of the nodal disease is better seen on the RM2, and perhaps some of the bone marrow disease is better seen here on the PSMA scan. This is how the uptakes between the 2 measures, so there is some overlap, but the biodistributions are clearly distinct, as you can clearly appreciate with the naked eye. We're doing the same thing now at initial staging, and all 4 participants had at least 1 lesion found in the prostate with both agents. but there were also differences between the two. And this is one example where I would argue that in the prostate bed, it's easier to see the disease here on the RM2 than on the PSMA. And you will see the left prostate bed lesion, and this additional area that it's only seen on the RM2 and not identified, at least easily, with PSMA. This is a lymph node that is seen on both scans. And this is a lymph node that I believe it's easier seen on the bombacine than it is on the PSMA 11. In fact, we did not call that prospectively because it was so close to the ureter. And the pathology in this case came back confirming the findings. This is another interesting example. On the top, the RM2, on the bottom, the PSMA, and you will see that what lights up on PSMA doesn't light up on bombacine and vice versa. And pathology confirmed disease in both the areas that were seen on bombacine and the area that was seen on PSMA. If you want to read more about this, this is one article that tries to make sense of when to use PSMA, when to use bombacine, but it concludes that we need to have more data. This is work that has been done in Chile with a partner of Piramal, Positron Pharma. They are the first, in addition to a site in Germany, to use this for therapy. They're also doing a comparison with PSMA 11. I think it is the wrong approach as far as stage of disease, because these are patients with too advanced disease. We really need to catch these patients at an earlier stage of disease. And this is how this is retained in tumor up to 168 hours, and you will note that it stays in the tumor, but it washes out from the pancreas, which is good because we don't want to expose the pancreas to too much radioactivity. As far as future directions, we have many plans, as you can see on this slide, mostly to find new indications, niche applications for RM2. We also work on software developments. If you look at that projection image, you would think it's fine. If you look at coronal, you have an artifact from overcorrection of scatter. We worked with a vendor to develop correction, and I think that we're doing pretty well with this software correction. This is a good review if you want to read more. And it looks like my conclusion slide went away, but to conclude, I think that there's a role for gastro-inducing peptide receptors, imaging and therapy. The cat is out of the bag with PSMA, so PSMA works great, but there will be a role, perhaps greater than a niche role, for these GRPR agents. And beyond prostate cancer, perhaps the next target should be breast cancer. I want to thank Helmut Macki, who is the inventor of this series of agents. It's now up to RM26. Fantastic collaborator, very generous with all of us. Wolfgang did some of this work initially in Freiburg, but also in New York. And then the team at Piramal, who have been superb in their collaboration with us. The work was funded by the Department of Defense through an impact award. So, you know, Rod, the Department of Defense is not only going to war against other countries, it goes to war against cancer as well. Apropos your comment in the prior lecture. This is a great team of collaborators that I'm happy to work with at Stanford. Sam, as the chair, is supporting our work. And I would like to end on a different note. We recently lost a very good friend who was the inspiration for a lot of the work that we've done, and we miss him. Thank you.
Thank you, Andre, for that very clear talk, highlighting the importance that biology will likely play in molecular imaging for years to come. Our next speaker is Dr. Hussein Jadvar, who is a professor of radiology and bioengineering at the University of Southern California. He's also the past president of the Society of Nuclear Medicine and Molecular Imaging, and also the American College of Nuclear Medicine. Hussein, we're looking forward to your talk as well.
Good afternoon. Thank you, Sam. Thank you, Rodney. First, I want to thank the organizers of WFNMB for this kind invitation. So I was asked to give an overview of prostate cancer theranostics, especially focusing on PSMA. And as you have already looked at the program, there have been a good number of these similar seminars in this conference. So obviously there's going to be some overlap. There may be some stuff that was presented before. I won't present here, but with that given, let's start. I have no disclosures. So this was already mentioned by Steve. The definition of theranostics is essentially a systematic integration of diagnostics and therapeutics using either the same agent or similar agents. The platforms can be nanotheranostics using nanomedicine technologies, or optotheranostics if you're using optical technology, or magnetotheranostics if you're using primarily magnetic resonance imaging. When we talk about radiotheranostics, we are focusing, of course, on radionuclides, and this is what we're going to talk about today. The idea here is the kind of a two-way highway. You see, treat, and then after you treat, you go back again and see how you did, and then you go back and forth. It's a kind of a pendulum going back and forth between this see and treat issue. This was also mentioned by Steve. Radioiodine actually is a classic radiotheranostic agents, and Saul Hertz was the first at Mass General Hospital who used it in one of his patients with the I-130 actually, that was provided to him from a cyclotron facility across the Charles River from MIT, and in 1941. Actually, I think it was March 31st, 1941. Then later on, the first patient with thyroid cancer was treated in 1946, 5 years later. And the first paper that came out regarding not only the Saul Hertz experience, but also a group in Berkeley who did a similar thing in 1942 in the Journal of Clinical Investigation. We celebrated at the SNMMI during my presidency in 2016 in San Diego, the 75th anniversary of what Saul Hertz did, and one of my missions as a president was to try to establish this therapy center of excellence that I'm glad was established. It's now a few years old, and Steve Larson was the very first awardee for the Saul Hertz Award. Now, these are the different platforms that are either currently used or under development for theranostics for different disease problems, thyroid cancer, neuroendocrine tumors. And Andre already talked about the GRPR platform. And earlier on, we heard about neuroblastoma, for example, from Steve, and lymphoma in a prior session by Rich Wall. So, but what I'm going to talk about is going to be on basically a summary of the PSMA platform. And by the way, you see here that there are only very few FDA-approved agents at the moment, but I think this is going to increase in time. Well, prostate cancer is definitely a major public health problem. This was already mentioned. You can, in the United States, the most recent data shows that approximately 1 out of every 7 men will eventually develop prostate cancer at approximately median age of 66 years old. And 1 out of 39 of men will die from this disease. In fact, there are more men dying from prostate cancer than women are dying from breast cancer. And you can see that the incidence and mortality are especially high in some areas of the world. For example, in North America, Australia here, for example, in New Zealand, and in Europe, the incidence is rather high. That may be due to PSA screening that is going on, and that's probably influenced by that. But in some other areas of the world, like Uruguay, that you see down here in South America, that may be related to genetic factors, socioeconomic factors, or related to access to care. So it's a complex problem, and it's definitely a public health problem. Now, this is a nice summary. You've seen this before. It kind of summarizes what the natural history of disease is here. There are three specific phases of the disease. One is down here, when the patient is initially diagnosed with prostate cancer. Most men right now are diagnosed with localized disease, about 85% of them, and that's because of the PSA screening. It's probably influenced by that. And they are taken to be treated for curative intent, and that's usually radical prostatectomy or external beam radiation therapy. But as was already mentioned, there is a rather substantial number of men, 30% to 40% of men who had the curative intent treatment eventually end up with biochemical recurrence of the disease, and you get into this kind of second phase in here when you try to use the tools you have, including imaging, to see where the disease comes from, because that, of course, makes a difference in how you're going to approach the patient for the appropriate treatment. And then, of course, when, as was already also mentioned, when the patients fail the androgen deprivation therapy, they get into this castrate-resistant disease, which is actually bad news, because at that point, the median survival of those men with metastatic castrate-resistant disease is only about 18 to 24 months. Also this graph here shows that there are different treatments that are common at different phases of the disease. Similarly, different imaging agents or imaging modalities may be best suited for the different phases of the disease. In other words, it is not one agent or one modality that is going to cover the entire spectrum. So we have to think that, what would be best for that particular state of the disease. Now, I have also added here the PSMA radioligand therapy, which we will talk about, and that may be a new added treatment type in this phase. Perhaps it can also be pushed even earlier, but we need data on that. And then there is also PSMA radio-guided surgery. For the urologist to have a better chance of finding exactly where the small but involved nodes are there, so that they can dissect it out. In fact, one of the reasons that we see 30% of men fail radical prostatectomy is because we never did a good job in staging them in the first place, and that can change. Now, with regard to different tracers that are available, PET tracers that are available for prostate cancer, you see a kind of a partial list in here. We have the FDG, of course, for glucose metabolism. That was some of my early work on that one. And then we have the lipogenesis traces, choline and acetate. We have the amino acid type tracers, including FACBC or fluciclovine, which is now FDA approved for use in biochemical recurrence of patients with prostate cancer. Then we have the cellular proliferation markers, FLT and FMAU. FMAU is the one that I'm personally doing research on. And then Steve already talked about FDHD, and GRPR was just presented by Andre. And now we are going to focus on PSMA. But this is just a partial list, actually. And here's a nice picture. You can see all these different tracers. The first two, FDG and NAF, of course, are the most typical ones in the clinic that we use today. The acetate and choline as lipogenesis tracers, RM2 was mentioned before, and the most, actually the only PET tracer that is specifically FDA approved for prostate cancer in biochemical recurrence is the last one, the fluciclovine, and you also see the biodistribution of the PSMA here. So what is PSMA? Prostate-specific membrane antigen. The whole thing is a misnomer. It's not, first of all, antigen. It's a transmembrane protein. It's actually an enzyme. It's not specific to prostate. It goes to other tissues in the body, not necessarily to prostate only. And also, it's not specific to cancer, prostate cancer. It can go to other cancers too, and I'll show you some data on that too. And also, it is not even specific to cancer. There are benign conditions that also will accumulate PSMA. Despite all of that, it turns out that actually it could be quite useful in the setting of prostate cancer as a biomarker. There are a number of different PET tracers now available. The granddaddy of them with regard to more recent effort was the gallium-68 PSMA-11 from Heidelberg, and then there was a lot of interest in F-18 type label, so that for the future that it can be widely distributed if it really gets into the clinic. And you see a number of F-18 type label tracers like PSMA 1007, which is actually structurally and from point of view of biodistribution is very similar to PSMA 617. So those two can kind of be in tandem for a theranostic pair. And then you have the DCF-PYL also that is being a second generation F-18 labeled PSMA tracer that is also being actively looked into. Now, the difference between all of these different agents are that they are small molecule inhibitors of the PSMA, and the target is the extracellular moiety of this large transmembrane protein, as opposed to what was FDA approved a long time ago, prostacint, that was radio-labeled with indium-111, and that targeted the intracellular moiety of the transmembrane protein. Which was never took off because of the poor target to background ratio, and the fact that actually for the molecule to get in there, the cell should have been dying or dead, and it couldn't really image the viable viable live tumors. What is the distribution of what we have available in the United States right now? Well, PSMA is being done. You can see the list there at some of the major academic centers around the country. There is also choline. C11 choline is FDA approved, and it is also available at some centers. And then fluciclovine, which was FDA approved in 2016. Actually, you can see the list is, of course, bigger or more. And we also use it at our center at University of Southern California. So with regard to gallium-68 PSMA-11, which used to be called HBDCC, you see the biodistribution here across time. There are two tumors here that are shown by the red and blue arrow, and you can see that the activity in the tumor actually increases with time. There have been some papers out there showing that it may be best to image at 2 or 3 hours for a better target to background ratio, especially in the prostate bed, although because of the clinic workflow, most of the studies that you see are done at 1 hour post administration. So you see there's a relatively intense uptake in the lacrimal glands, in the salivary glands, parotids, submandibular, sublingual, all the salivary glands, the cortex of the kidneys, some variable uptake in the bowel, and there is urinary excretion, and relatively mild to moderate uptake in the liver. Now, there are false positives that you can have. There is normal uptakes that you have to be aware of. Celiac ganglia has been shown that they can take up the tracer. This is an example that you see on this slide. It can go from neck all the way down to the thorax. And every time you open up the Clinical Nuclear Medicine Journal, you see one case report showing that there is a false positive PSMA in something. And this list is growing, as I showed some of this in here, adenomas, hemangiomas, and other type of benign or inflammatory tissues. This is, for example, a case of Paget's disease that had nothing to do with prostate cancer or any cancer, and it was PSMA positive. As I already mentioned also, of course, PSMA is not specific to prostate cancer. It can go to other cancers. This is an example of a patient who had rectal cancer, but there is actually the list of PSMA going to other cancers is also growing. Here's a nice review paper just published in the European Journal of Nuclear Medicine. I don't expect you to read all those, but there is actually a very nice list of all the different types of cancers that PSMA has been shown to be perhaps useful for. And that actually is not bad. That may be meaning that PSMA use may not be limited to prostate cancer, but also could be used in other types of cancer, even as a theranostic agent. You can have false negative results, and that usually is related to very aggressive, poorly differentiated tumors with neuroendocrine differentiation. This is an example of a patient who had a PSA of 5.8 and had a rather aggressive Gleason score of 9, but the scan was falsely negative. You can see that this patient, again with known metastatic prostate cancer, had essentially a negative bone scan, had also essentially negative PSMA, although there may be some hint that there may be some lesions in the right hepatic lobe, but then it was very clear that this patient had neuroendocrine differentiation of prostate cancer, and in fact that opens up the door for possibility of using the agents like Lutathera, for example, in this specific set of patients who may benefit from treatment. This is another case showing that this patient had neuroendocrine differentiation of prostate cancer. Again, negative gallium-68 PSMA. DOTA-NOC in this case was quite abnormal with extensive disease in the abdomen and in the chest and even in the bone. For example, you can see in the right arm. And also FDG was also quite positive in this patient, although not exactly concordant in specific areas with DOTA-NOC, but you can see that FDG is actually quite useful in metastatic castrate-resistant metastatic prostate cancer. There is also data coming out that you don't have to even have neuroendocrine differentiation. There are some patients who have dedifferentiated acinar prostate cancer, and these patients may also be falsely negative on PSMA, or at least the disease can be completely underestimated. In this case, you can see that this patient is not particularly a good candidate for the theranostic pair for radioligand therapy, and you can see the FDG is actually the better tracer here to show the exact extent of disease. So these are the things to be aware of. This is another case, again, showing that the patient had a Gleason score 3+4. There were obvious enlarged metastatic nodes you can see here in the left pelvis on CT, but it was completely non-avid on PSMA. Actually the biopsy turned out not to be even positive for anything neuroendocrine. So this is another entity that we have to be aware of. So let's quickly go over different phases of the disease according to the natural history of disease that I showed you, the graph, the primary cancer and staging. This is the very recent study just published in JNM, showed that in fact when you see something in the prostate, it's probably because of prostate cancer on PSMA PET. They did not see any specific correlation between SUV max of prostate cancer and Gleason score in this case. But the data showed that there is very little or no uptake in the normal or BPH states as opposed to prostate cancer. Here is a PSMA PET multiparametric MRI, again in a patient with primary prostate cancer. You can see on the MRI that there is, on the diffusion-weighted imaging, there is also an abnormality with restricted diffusion with a low ADC, apparent diffusion coefficient, that exactly correlates with where the PSMA is accumulating. Now, there are, as we noted, there is a urinary excretion with PSMA-11, and it is possible to do the imaging earlier on. Don't wait until 60 minutes so that you can do the imaging before the urine arrives into the bladder to see the lesion much better. For example, you can see right here that the bladder is kind of empty, but you can see the tumor right at the base of that bladder. This is the F18 label, the first generation, and this report showed that the specificity of this particular tracer is better than MRI, and they did show some positive correlation between SUV max and Gleason score as opposed to what the pathology or immunohistochemistry showed that I mentioned earlier. The German group looked at again on prostate cancer, and they wanted to know if there is a relationship between Gleason score and PSA with the intensity or the SUV max that you see. And they did actually see a rather, Okay, they did see a positive kind of a line in here that the higher the Gleason score, there was a tendency for the higher uptake of the tracer. And then also the success rate of seeing the primary tumor was higher with the higher Gleason scores. This is, again, another similar study that showed that there is a difference between low to intermediate type cancers as opposed to high-risk cancers, and the high-risk cancers by the D'Amico criteria will show higher uptake of the tracer. This is another study that not only looked at the Gleason score, but also you can see the PSA. So there's a lot of scattering in here, but still it shows that as the PSA went up, the intensity or the SUV max in the primary tumor also went up. And they suggested that if the patient is in the intermediate to high risk category, and they did have even a multiparametric MRI, they should undergo a PSMA PET-CT if it's available for better staging prior to curative intent treatment. And this is an example of that. So this is a patient who had a Gleason score of 9, very aggressive prostate cancer. PSA was high, 50. So this by D'Amico classification, this patient is considered high risk. So obviously, the urologist decided to do imaging and make sure that there is no metastasis. And they did the bone scan, they did the CT, there was nothing there. But the patient entered into a protocol, and there you can see very obvious actually extensive disease, metastatic disease in this particular patient. So this patient was absolutely not a candidate for curative radical prostatectomy, and he would have probably not decreased his PSA, of course, to the undetectable levels, and would have had biochemical recurrence very fast. This is another tracer, the PSMA 1007, which I told you has a similar biodistribution and a structure to PSMA 617, the therapeutic counterpart. The feature of this is that it has a low urinary activity. You can see the biodistribution of the tracer across time, but the fact that it has low urinary activity is a good feature, and also the similarity to 617 is also a good feature. This is a study using the PSMA 1007 with a hybrid simultaneous PET-MR. You can see the abnormalities both on MRI and also on the multiparametric MRI and also on PET that are concordant. And they came up, the authors actually came up with a nice summary of what their protocol was, which took about 1 hour to do the entire PET-MR scan. Let's talk about biochemical recurrence. There has been essentially most of the studies that you see in the literature are in this phase of the disease for almost all tracers in PET, including PSMA. So here you can see that there is a positive correlation between the PSA. As the PSA goes up, you also see the uptake in detection rate to go up. Also, very interestingly, you can see in this very low PSA levels, there is a nearly 50% detection rate, which is higher numbers that we have seen with other tracers. This is a PET-MR, a hybrid PET-MR study with GE, again showing that in this very tough situation of 0 to less than 0.2 nanogram per milliliter of PSA, nearly over 40% detection rate with this particular tracer. This is with the 1007. Again, you can see this patient has had only a PSA of 0.08. This is really, really low PSA. And of course had negative conventional imaging, but definitely showed some abnormalities on these particular scans. So that just tells you that there could be definitely a game changer with regard to the imaging evaluation of these patients. So this is a biodistribution, the biodistribution of the DCF PYL tracer you can see across time. Of course, there is some urinary excretion on this particular tracer. This was compared to gallium-68 PSMA 11 in one paper in a limited number of patients. And essentially, the paper showed that the F18 label agent is not inferior to the gallium-68 PSMA 11. However, there was a caveat because they used different activity levels, and also the tracer uptake times were not exactly equal. So it kind of favored the F18 label. But there are more studies needed to be done for that comparison. If you're interested to get a summary of what could be the advantages or limitations of using one over the other type agent, here's the paper that was published last year. I don't have time to go over that, but you can see the table here. What about comparison with other tracers? With F18, looks like it's doing better job than fluorocholine. Another example in here, again, a lower background activity in the liver than choline shows the lesions in the liver better, also higher activity in the retroperitoneal lymph nodes. This is a summary slide that looked at choline, PSMA, and FACBC or fluciclovine, which actually has been approved by FDA, and you can see that the PSMA, which is the red bars, they're all higher than the other two tracers across all different PSA levels. This is a meta-analysis that was done, and again, if you see here in these plots that, if you go the diamond for the 0 to 0.19 nanogram, if you come down, again, you get around somewhere 40 to 50% detection rate across these studies. Just to show you some examples, with regard to management change, this was a recent study published by Tom Hope, showing that the information provided by gallium-68 PSMA PET in this group of patients can have a major impact in almost 60% of these patients. The Australian study by Paul Roach, nicely done and published recently in JNM, showed that similar results of overall management change around 50% in these 431 men who were studied at 4 centers. Another similar study, again, recently published in the same journal that the Australian study was published. They had a little bit lower management change, but that could be due to differences with their patient population. Also, they had a lower detection rate at less than 0.2 PSA. Here is another very nice paper that was published out of UCLA, just published in the JNM, and they looked at 270 men with PSA less than 1. This is very, very low PSAs where the radiation oncologist is very interested because the progression-free survival would be much higher for patients who receive salvage radiation therapy to the treated prostate bed if the PSA is very low. And they found out that 19% of patients with at least one lesion that was positive on gallium-68 study was not covered by the clinical tumor volumes that the radiation oncologist would have used anyway. So this is a kind of a rigid structure. You can see all these yellow things or yellow dots are the different locations of the disease that was detected across all these patients. And what was going to be treated was only this green area in the pelvis, missing a lot of lesions. What about metastatic disease and treatment response? Very recent study also tried to summarize if bone scan is needed if you have a gallium-68, and it turns out it says it's possible that we may not even need the bone scan if you actually have PSMA PET done, but that, of course, needs a lot more study to be done. What about the effect of different drugs? It's been shown that when you give ADT, actually the PSMA expression goes up, and this can be explained in this schematic by the fact that the androgen receptor, when it's blocked by antagonists like enzalutamide or by abiraterone, then it will kind of releases the enhancer region for the PSMA gene, and you start seeing more PSMA. And that can, in fact, be useful for increasing the sensitivity of the test and also for treatment later. Hope also showed it in animal studies, you can see here, and also in human studies, that ADT will increase the uptake in the lesions of these patients. What about treatment response? Very, very limited data on this. This is a very recent paper published in European journal showing that with docetaxel, you can actually have lower PSMA expression in these patients with successful treatment as determined by RECIST criteria. However, there needs to be a lot more work in this area. What about the theranostic pair? Now, this was a kind of initial images that really made people excited with showing, resolution of the disease, as you can see in here, or some dramatic images like that, that a very extensive disease in this patient who has been really treated very heavily with everything that the doctor had, and now after 4 cycles, basically showing a dramatic PSA response and also image response in this case. I don't have time to go to the dosimetry, but parotids received the whole dose, the major amount of the dose. Here is another study from Germany that looked at not only you see this treatment response, that the patients who respond, they tend to have better outcome and better overall survival versus if you do nothing. And this has also been shown by Rich Baum from Germany again, and also they tried to use the RECIST criteria and EORTC criteria to show that in fact you can use those tools also for looking at treatment response as well as the PSA. This is the protocol, the typical protocol that is being used. And again, if you're interested, you can go to this Fendler article that was published in JNM 2017 to get the details. But overall, the PSA response is good. It can be expected in greater than 50% of patients. Some patients, about 30%, don't respond on after the first cycle, but they tend to respond after the second or third cycle. We don't understand exactly why, but that may be due to tumor heterogeneity or the different distribution of the radionuclide. The imaging response it can be seen in almost a third of the patients. There is actually pain relief, which increases the quality of life, of course. And there is the predictors of bad outcome is when the patients have visceral metastases, the ALK phos is high, that means there's a lot of tumor burden in the bone. Here's some studies again showing what I just said, that regarding the better overall survival in responders in comparison to non-responders, and that you don't have to give up after the first cycle if the treatment doesn't work. And now there is a study that was just published in the current issue of JNM that shows that you can actually escalate the dose to much higher dose than what is typically used, that's 6 gigabecquerels. And there seems to be, you can even push it up to almost 10 gigabecquerel without really having major adverse events, although in some patients, thrombocytopenia was becoming a problem. But this shows that there is room still to increase the number of cycles or the amount of the dose that the patients receive. And I'm sure you've seen these dramatic images again before in other sessions that a patient with very, very heavy disease, in this case, who received the lutetium-177 PSMA treatment, did not respond, and then was treated with the alpha particle, actinium-225, and had an excellent response, as you can see in here, after just 3 cycles. And there is, of course, another one that was showed by Mike Sathekbi from South Africa, showing that the bismuth-213, also another alpha emitter, can do the same thing. Now, we don't understand exactly why this patient didn't respond again to 2 cycles of lutetium, but then ended up responding to alpha particle quite well. But these are interesting observations that need to be looked at. Xerostomia was mentioned. In fact, if I go back, look at this patient with Look at this patient with alpha therapy. Here's the amount of activity in the parotid glands or salivary glands. And now after the 2 actinium, there's not much going on in there anymore. That means that some of that, the parotids or salivary glands were kind of fried. But in any case, that can be a problem. Although it seems to be rare with lutetium-177, some of the remedies that people have been using is not really working. But this is something that needs to be looked at eventually. So in summary, PSMA, of course, PSMA radioligand therapy is really not curative. The SUV that you see on the scan, on the imaging scan, is not necessarily correlated to response. Prior treatment responses prior therapies, chemotherapy or anti-androgen may not correlate with the response that you may expect from radioligand therapy. I already mentioned the predictor of prognosis, and also there's a prospective clinical trial that is going on right now. Last few slides, just to show you some literature if you're interested in. It is remarkable that this PSMA, whether for imaging or treatment, is not even FDA approved, and we are rather in the earliest stages of this to learning we are learning as we go on. But there are a good number of papers now showing about how to read it, and they're standardizing, which is very interesting. So this is a nice paper by Mike Hoffman and of course our co-chair here, Rodney Hicks, that looks at the clinical, normal biodistribution and some pearls and pitfalls. There is a PSMA RADS now, just like we had BI-RADS for breast cancer, long RADS, TI-RADS, PI-RADS, all that stuff, RADS that we have. Now we have a PSMA RADS, so that you can refer to. There's also the type of a TNM classification that has been proposed. Here you can see called PROMISE. These are all recent. PSMA is not approved in USA. This is a nice editorial by Mike Graham that looked at this, and the clinical trial network of the SNMMI is trying to help kind of with a consortium of academia to trying to bring this eventually, hopefully, to market and approval. And the radiomedics, the UCLA and others are working together to, with regard to lutetium-177 PSMA for doing that clinical trial. So the landscape is evolving. There are the clinicaltrials.gov reports almost 24 out of 61 trials that are going on PSMA. So it's a very active area. And you can see the other tracers that are also being looked at right now with prostate cancer. In Australia, where we are right now, there's a THRAP clinical trial that compares the lutetium treatment with cabazitaxel in a randomized treatment. And if that's positive, that hopefully will stimulate use of PSMA RLT in an earlier disease. And the last couple of slides, there are a couple of editorials that I wrote about some of the unresolved issues and things that we need to think about as this goes on. This is a very nice, I think, summary, one of the nicest summary I've seen of the PSMA theranostics, just published in the European journal that you can refer to if you're interested. The SNMMI Image of the Year, of course, was received for this work. As you can see, there was a lot of excitement in 2015, and later that was for their RLT, and for their radio-guided surgery that I showed you on my initial slide, also received the Image of the Year in 2017 for the dual probe type, dual modality probe based on PSMA. I had a privilege of hosting, guest editing a supplement to JNM, which was on prostate cancer theranostics. And if you're interested for more information, you can refer to that. That was published in October 2016. And with that, I acknowledge my funding, and thank you very much for your time. I'm sorry I went over time a little bit. Thanks.
Thank you very much, Hussein. Really covered a huge amount of territory in a very complex area that's still evolving. Thank you, everyone, for coming to this final session of the day. I'll just remind you all that the plenary session tomorrow will start promptly at 8:15 for all of you who wake up in time. Well done for sticking it out to the very end of the day. Thank you very much for coming.